Chapter 15 is local anesthetic complications. We're going to talk about local and systemic anesthetic complications, and then the three primary categories for the complications. We're going to talk about possible complications as well as the management and preventions, such as needle breakage, pain during the injection, burning, hematoma, facial nerve paralysis, paresthesia, trismus, infection, edema, soft tissue trauma, and sloughing of the tissue. We're also going to talk possible systemic complications and the management and prevention of those as well, allergic reactions that may arise, and then we're going to list and discuss the common drugs used in the dental emergency kit. We're also going to talk about signs, symptoms, and management of different emergency situations. So starting off, localized complications occur in the region of the injection, and they can be attributed to anesthetic needle administration technique or anesthetic drug administration. While rare, complications can happen, so it's best to be prepared. We're going to discuss table 15-1 on a later slide, but just keep in mind that the difference between localized complications and systemic complications. Systemic complications are attributed to the drug administration, whereas localized complications occur in the region of the injection and can be attributed to different things. So the categories of local anesthetic complications, there's 3 different categories. They're going to be discussed in detail on the next slides, but there's primary or secondary complications, mild or severe complications, and transient or permanent complications. So primary complication is experienced by the patient at the time of the injection. Secondary complication is apparent after the injection is completed. Mild complications will resolve without requiring treatment, but severe complications will require a definite plan of treatment to resolve. An example of primary complication is a burning sensation at the time when the drug is administered. As mentioned, so secondary complication is caused by the injection of the anesthetic drug, but it's experienced by the patient either shortly after the injection or later on. The mild complication, an example of that would be a burning sensation. It's temporary, it's resolved shortly after the deposition. Severe complication, an example of that would be anaphylaxis. So that requires a immediate treatment and drug intervention as well. All right, transient complications may appear severe at the time, but their observation will eventually resolve without any residual effects. So an example of that would be a hematoma, which can cause severe swelling and bruising, but will resolve over time without any residual effects. Permanent complications leave a residual effect, and a example of that would be nerve damage associated with the IA block. That damage could last for a few weeks, months, or even indefinitely. Local complication, needle breakage. So the cause of needle breakage is a sudden, unexpected movement of the patient or the needle. It can be caused by poor technique of the clinician as well. Prevention would be to communicate with the patient during the injection. Use long, large gauge needles. Do not bend the needle. You want to advance slowly, never force the needle, do not make any sudden direction changes, and never insert the needle to the hub. If you insert the needle to the hub, you have a greater chance of needle breakage. The needle gauge that's usually reported as breaking off in the patient's mouth is a 30 gauge needle, and table 15-2 in your book has a summary of the local complications, causes, prevention, and management. The management is to remain calm, keep your hands in the patient's mouth so that they don't close down. You want to remove the needle fragment if visible, refer to an oral surgeon, it's always necessary, and document the incident carefully and thoroughly. You want to keep your hands in the patient's mouth to prevent the patient from swallowing or prevent the needle fragment from embedding further into the tissue. And this is why it's super important to always keep hemostats or cotton pliers on your tray whenever you're providing local anesthesia or giving local anesthesia. You want your hemostats to be open and ready to use. And that's going to be what you use to remove the needle fragment. You want to be able to keep one hand in the patient's mouth, one hand to retrieve the hemostats. That's why you want them to be open and ready to go. It's super important to be prepared. You never know if this is going to happen or when it's going to happen. You want to be prepared with those hemostats. The next complication is pain during the injection. The cause of this is careless technique, dull needle, maybe a barbed needle, or rapid deposition of the local anesthetic. The prevention would be proper technique, and improving one's technique is a lifelong learning process. It is the dental hygienist's responsibility to make every effort to take the necessary precautions to prevent pain during the injection. So you should know proper technique. You want sharp needles. How frequently during the dental appointment should needles be changed? So after every 3 to 4 needle penetration, you want to change that needle. Otherwise, you can have a dull needle or barbed needle. You also want to use topical anesthetics. Sterile anesthetics, you want to inject slowly, and you want to use room temperature solutions. The management of pain during injection is going to be good communication, reassurance that the pain is only temporary. Think about some things that you can say to reassure the patient. Think about some things that a dental hygienist should not say that might not be comforting to the patient. And then also, you want to think about the things that should be documented about the patient's behavior, feelings, or comments. Okay. The next complication is burning during the injection, which the causes of this is contamination of the local anesthetic, heated anesthetic cartridges, expired anesthetic solutions, or rapid deposition. The prevention would be to never store the anesthetic cartridges in disinfectant solution, and make sure you know how to know if your local anesthetic cartridges are stored in disinfectant solution. You want to store them at room temperature. You want to always check the expiration date. You don't want to use cartridge warmers, and you want to make sure that you are injecting slowly. Keep in mind that the patient may experience a normal burning sensation during the deposition of the anesthetic solution because of its acidic nature. The management is to reassure the patient that the burning will only last a few seconds, and the burning sensation is not present after the anesthetic wears off. The next complication is a hematoma, which the cause of this would be inadvertent puncturing of a blood vessel, over insertion of the needle during a PSA injection, improper technique, multiple needle penetrations. If you look at the causes of hematoma, these are all poor techniques. You can refer to figure 15-2. The prevention would be to use a 25 gauge short needle for a PSA. You want to know your anatomy. You want to modify the injection technique for patient size, minimize the number of needle insertions, and maintain a good technique. So there's going to be swelling. You want to apply direct pressure, apply ice to the region at the time of the incident, and then advise the patient to apply warm packs the next day. You want to discuss the possibility of soreness and limited movement. Communicate with your patients. Let them know what to expect. Instruct the patient that swelling and discoloration will disappear after 7 to 14 days, and you want to dismiss the patient when the bleeding has stopped, so you don't want to continue on with treatment. A hematoma is most likely to result following the administration of a PSA, and the two next most common injections associated with hematomas are the IA and mental blocks, which those 3 injections are the most common injections for positive aspirations. The next complication is transient facial paralysis, which is what happens when local anesthetic is deposited in the parotid gland. This is why it's super important that you have proper technique for an IA block, and it's important that you contact bone prior to depositing the solution. If you don't contact bone, you're at risk for depositing into the parotid gland. If you don't contact bone, you want to redirect the barrel of the syringe more posterior and reinsert and make sure you contact bone. With the management, you want to reassure the patient that paralysis will only last a few hours and ask the patient to remove their contact lenses, close eyelids manually, and make sure you document everything that happens. So they have a temporary loss of function of facial expression muscles, but it's not permanent. Usually it's not permanent. Keep in mind where the parotid gland is located, and that's on the posterior border of the ramus. Okay. You can refer for further information on this to figures 15-3 and 15-4 in your book. The next local complication is going to be paresthesia, which the causes of this is irritation to the nerve following the injection of a contaminated solution. Swelling or edema places pressure on the nerve and can cause paresthesia. Trauma to the nerve sheath, which electrical shock can happen. Hemorrhage around the nerve sheath. Paresthesia is defined as the persistent anesthesia or anesthesia well beyond the expected duration, or altered sensations such as tingling or itching well beyond the expected duration. The nerve that this commonly occurs on is the lingual and IA nerve. And with articaine, articaine local anesthetic has a higher occurrence for this paresthesia. Now, the prevention would be store the anesthetic cartridges properly. You want to avoid placing the cartridges in a disinfectant solution, and you want to utilize proper technique. Proper technique includes not moving the needle while it's deep in the tissue. Almost completely withdraw the needle from the tissue and then redirect the needle. With the management for the paresthesia, you want to reassure the patient, arrange an exam with the dentist, consult an oral surgeon, document the incident, and inform insurance carrier of the incident as well. The time frame in which paresthesia will typically resolve is within 8 weeks. And you just want to document everything, how the patient was feeling, the behavior, where they were feeling the numbness or the tingling, and the extent of that numbness and the tingling, what injection you were giving, if the patient had an exam with the dentist, or document that you referred them to an oral surgeon. The next local complication is trismus. The causes is trauma to the muscles of the infratemporal space, multiple needle insertions, contaminated needles, depositing contaminated solution, depositing large amounts of solution in restricted areas, hemorrhages, or low-grade infection. Trismus refers to the reduced opening of the jaws caused by a spasm of the muscles of mastication. The prevention of this would be to store the anesthetic properly. You want to use sharp, sterile needles and appropriate injection technique, minimal amounts of solution, and then of course you want to deposit the anesthetic slowly. The management would be to, if they're experiencing trismus, arrange for an exam with the dentist. Heat therapy can help, jaw exercises can help, antibiotic treatment for infection if there's infection, and you may want to refer to an oral surgeon for severe pain. Document everything. If they have severe pain, the extent of the trismus. I think that everybody here may experience trismus, could possibly experience trismus when you guys practice injections on each other. It's something that happens but will go away, and then there's different ranges of trismus as well. It's not complete inability to open the mouth every time. Another local complication is infection. The causes of this is contamination of the anesthetic needle prior to the injection. This happens from this is why whenever you remove the needle, you uncap the needle, you want to make sure that that needle never touches anything else other than the site of injection, and then where it's going with the injection. You don't want it to touch anywhere else. So on the outside of the cap, you don't want it to touch your glove, you don't want it to touch the patient's lip, you don't want that needle to touch anywhere else, because then it is contaminated. Improper handling of the anesthetic armamentarium is another cause of infection, and also improper tissue preparation. For prevention, you want a sterile needle, so sheath needle before and after the injection. Be aware of the location of the uncovered needle at all times. Utilize appropriate infection protocols. Store the anesthetic properly, and you want to wipe off the diaphragm of the cartridge with topical antiseptic. Infections caused by administration of local anesthetics are rare when sterile disposal needles and single-use glass cartridges are used. But the management, you want to treat, so it's going to be treated initially as trismus. After 3 days, begin antibiotic therapy as prescribed by the dentist or the physician. Low-grade infections are very rare and often not easily recognized. The next complication is edema. The causes is trauma during injection, administration of a contaminated solution, hemorrhage, infection, allergic response may produce airway obstruction. So much swelling that there's airway obstruction. The prevention would be appropriate infection control, appropriate technique, and adequate pre-anesthetic assessment. The management of edema depends on what caused it, so you can refer to figure 15-6 in your book for more information on this one. Next complication is soft tissue trauma, which is caused by the lips, tongues, cheek being traumatized by the patient while they're numb and not realizing that they're causing that trauma. The prevention, so this is normally seen in children and in mentally and physically disabled patients. The prevention would be to select an anesthetic with the appropriate duration for the duration of the treatment that you're providing. You want to warn the patient not to eat or drink hot fluids or bite themselves, so be aware of that. Instruct the parent or guardian of danger, and then you can also place cotton rolls between the teeth and the soft tissues, or warning stickers that can be used to remind the patient and the guardian of the dangers associated with being numb. The management would be analgesics for pain, antibiotics prescribed for infections, and this is if they have the soft tissue trauma, so warm saline rinses to decrease the swelling and discomfort. Petroleum can be used to coat lips to minimize discomfort, and you can use the Oroverse to reverse the effects of local anesthetics containing vasoconstrictors in the soft tissues. That Oroverse, it's an alpha adrenergic receptor antagonist. The active ingredient is the phentoalanine mesylate, which is it competes for the receptor sites of the vasoconstrictor, thus encouraging faster metabolic reuptake of the local anesthetic due to the increased vasodilation. Oroverse is as potent of a vasodilator as is the local anesthetic it follows. The duration of action is usually 30 to 45 minutes. There's no known toxic levels of it, and it is metabolized in the liver, excreted by the kidneys, with 10% of it being unchanged. The onset of action is rapid, and the half-life is approximately 19 minutes. It is a pregnancy category C, and it's packaged in an anesthetic cartridge with a translucent green label and blue aluminum cap. It's recommended for pediatric and special needs populations. When properly used, the anesthesia time is reduced by almost half. It's contraindicated for children under 6 years of age or patients weighing less than 33 pounds, people with sensitivity to the active ingredient, or those with the history of myocardial infarction, angina, or coronary artery disease. Now, Also keep in mind that this Oraverse is super expensive, so a lot of offices will only use it when it's needed because of the price per cartridge of this Oraverse. The next complication is tissue sloughing. So this is prolonged use of topical anesthetics. The prevention is to only use the topical anesthetics for their manufacturer's recommendation, which is 1 to 2 minutes, and you want to avoid high concentrations of vasoconstrictors. The management, usually there's no management, this requires no treatment. One thing to keep in mind is that a sterile abscess may develop after prolonged ischemia, usually on the palate, which the anesthetic formulation that is more likely to cause prolonged ischemia, which is potentiating the possibility of a sterile abscess, is epinephrine 1 to 50,000. You can refer to table 15-9 in your book for more information on this. The next local complication is post-anesthetic intraoral lesions, which the cause is trauma to the area of injection, and the prevention is going to be to utilize appropriate administration techniques. The management is topical anesthetic solutions or paste for discomfort. These lesions usually consist of recurrent aphthous stomatitis or herpes simplex. Lesions last for approximately 7 to 10 days, and the prevention of these lesions is unfeasible in susceptible patients. But you can refer to figures 15-10 in your book for more information. Systemic complications, the prevention of this would be to do a thorough pre-anesthetic patient assessment and strictly follow all local anesthetic administration guidelines. Systemic complications associated with the administration of local anesthetics are rare, but the dental hygienist can prevent 90% of potentially life-threatening reactions just by reviewing their medical history and doing a thorough pre-anesthetic patient assessment. Another systemic complication is local anesthetic overdose. The causes would be biotransformation of anesthetic, which is unusually slow. Elimination of the anesthetic from the body through the kidneys is unusually slow. If the total dose administered is too large, or if there's absorption of the anesthetic from the site of the injection is unusually rapid. Or if the anesthetic is administered intravascularly, so this is why it's important to aspirate. The calculation of MRD is also very important for local anesthetic overdose and prevention. Predisposing patient factors would be age, so keep in mind that organs involved in biotransformation may not be fully developed in younger age groups, or they may be diminished in older age groups. With body weight, lower body weight increases the risks. Deficiencies, so genetic deficiencies may affect biotransformation of the drugs. If they have atypical plasma cholinesterase, that can affect the biotransformation. Gender, or disease, so presence of disease may affect the body's ability to biotransform the drug, may cause hepatic or renal dysfunction, or even cardiovascular disease. And with gender, may be potentiated during pregnancy. The predisposing drug factors would be vasoactivity, drug dosage, route of administration, rate of injection, addition of vasoconstrictors, and vascularity of injection site. So vasodilation increases risk, higher dose increases the risk, intravascular route increases the risk, rapid injection, of course, increases the risk. Addition of the vasoconstrictor decreases the risk, and increased vascularity increases the risk. Here is a table 15-1 of the local anesthetic complications. This shows complications associated with anesthetic needle or administration technique, and then complications associated with the anesthetic solution. The management of local anesthetic overdose would be to terminate the procedure and reassure the patient. You want to position the patient in a comfortable position and administer oxygen. Monitor the vital signs, summon for medical assistance if it's needed, and allow the patient to recover, and then you want to discharge them. Provide basic life support as indicated, and you may need to transport the patient to the hospital after stabilization. Um, Another systemic complication may be an epinephrine overdose. This is going to resemble the fight or flight response, and epinephrine and levonorepinephrine are the two vasopressor drugs currently combined with local anesthetic agents for use in dentistry in the US. An epinephrine overdose is more likely to occur when higher concentrations are administered, and these adverse effects last only about 5 to 10 minutes, but it's going to present as tension, anxiety, apprehension, nervousness, tremors, increased heart rate, increased blood pressure, throbbing headache, and hyperventilation. The management would be to terminate the procedure, position the patient upright, reassure the patient, provide basic life support if indicated, monitor the vital signs, summon medical assistance if needed, administer oxygen if needed, and allow patient to recover and then discharge them. Remember to follow the individual office policy about discharging a patient, and you always want to document the incident. This shows the clinical manifestations and management of a patient with an epinephrine overdose reaction. And so this is a nice table just laying it all out. The next one is allergic manifestations. So allergens or antigens are foreign substances that trigger hypersensitivity reactions. An example of this would be esters, which are derivatives of PABA, sodium bisulfate, which is the preservative in local anesthetics, and then topical anesthetics can trigger hypersensitivity reactions as well. Amides are not associated with PABA and do not produce allergic reactions with the same frequency as esters. With sodium bisulfite antioxidants, that's going to be antioxidants added to the local anesthetic solution to prevent the oxidation of epinephrine. Sodium bisulfate is also sprayed on fruits and vegetables to prevent discoloration, and also used to prevent bacterial contamination of wines, beers, and other distilled beverages. So, with that being said, sometimes you can ask certain questions to get a clue if somebody is allergic to sodium bisulfate based on where they use it. With topical anesthetics, benzocaine and tetracaine are ester topical anesthetics that can contribute to the allergic response. And lidocaine is the only amide anesthetic that may contain preservatives such as parabens, which could also induce an allergic response. The prevention of allergic reaction is to ask a lot of questions and write down the patient's responses to create a document that will be self-explanatory for the next dental professional. When was the last time you experienced this response? Describe exactly what happened. What position were you in during the injection? What was the time of sequence of events? What drug was used? What amount of drug was administered? Did the drug contain a vasoconstrictor? Were you taking any other medications at the time? What is the name and address of the doctor who is treating you? The pre-anesthetic patient assessment is the most important part of the prevention of allergic reactions. You can refer to boxes 15-1, 15-2, and 15-3 for more information. The management, so time of onset of symptoms determine how the dental hygienist will manage the reaction. If there's delayed symptoms, it's less serious. If there's immediate symptoms, more intense and serious anaphylaxis can occur. Anaphylaxis can be life-threatening. So for delayed symptoms that appear as arrhythmia, hives, treat with Benadryl. For more serious reactions, it may require being treated with epinephrine. Corticosteroids should be given for severe allergic reactions, and of course, always have an EpiPen on hand if needed for allergic reactions. Management of a medical emergency. So you can refer to figure 15-14 to see the actions taken by the dental hygienist in an emergency situation when a patient loses consciousness. You want to have proper training, you want to know phone numbers, you want to know the emergency equipment, what's in the drug kit, and you want to be knowledgeable in the recognition and management of the emergency. Drugs in a dental emergency kit are noted here, and so these are the common drugs found in the dental emergency kit, their action and uses, and the availability or doses. Refer to in your book to table 15-1 for the cause, signs, and symptoms and management of these specific medical emergencies. You will also learn about all of these in your medical emergencies course. Okay. All right, so for review, you want to avoid local and systemic reactions with proper pre-anesthetic assessment, proper communication, and careful choice of the local anesthetic agent and careful injection techniques. You want to record in red as a medical alert on the patient's medical history any conditions that place the patient in risk for an emergency. Hematomas can occur even if the clinician utilizes proper technique. Complete the appropriate consultations or referrals prior to the administration of local anesthetics. Utilize stress reduction strategies to prevent stress-related emergencies, and these stress reduction strategies are discussed in chapters 1 and 7. You always want to take baseline vitals so that you have something to compare that to should something go wrong. And you always want to use the lowest effective dose and never exceed the MRD for the patient. Record the type of drug and the doses administered in milligrams in the patient's chart. The reason why the drug and doses administered should be recorded in milligrams is because medical personnel are unfamiliar with dental cartridge dosage. So you want to use milligrams because it's more known throughout the different medical personnel. The office staff must be competent in the emergency equipment, what's in the emergency drug kit, and how to use that, when to use it. And then also the office emergency procedures. You want to conduct emergency drills often and know that thorough documentation is essential, including the instructions to the patient and the patient responses. That concludes this chapter, chapter 15. If you guys have any questions, please let me know.